Hello, everybody. Welcome to today's podcast. I'm really excited for you guys to hear from Dr. Bruce Werber. Today's guest. He's someone who honestly has spent decades healing people. First, both with his hands and now with innovation, and that's the part I'm really excited for you guys to hear about. So, Dr. Werber, welcome to the podcast. Why don't you take a second, introduce yourself?
Oh, thank you, Michael. Well, I'm Dr. Bruce Werber, a lower extremity surgeon for 40 plus years. I've been around the block a few times. I've practiced in Rhode Island, in Arizona, and I still do surgery, pediatric reconstruction in Honduras and India and El Salvador with a group called Operation Footprint. So we repair the children that have terrible clubfoot or post-polio or other traumatic deformities. And unfortunately, in these countries, they're shunned and they can't go to school. And so my group, actually, it's the same group I did my residency with back in the 70s and early 80s. And so we still travel after all these years to these locations to help out these children. But really the focus of my world has been in regenerative care. And actually since the mid-80s with platelet-rich plasma, everybody thinks, oh, that's new and great, but it's actually old technology. And then we added to that extracorporeal shockwave therapy, and that helped accelerate healing for patients. But really the game changer, an incredible miracle that we have access to is utilizing placental tissue after a healthy baby is born. The moms give us consent to take the leftovers, and we make that into regenerative products. And I think that's really going to be the focus of our talk today. But yes, I've been around the block. I've had lots of great experiences. I've had a wonderful, wonderful journey. I hope it continues for quite a while longer.
Yeah, I'm so fascinated by the and how you got to the placental journey. So yeah, like maybe take us back a little bit. It's hard for people to think kind of I'm in a similar boat. You're in a traditional medical world. Like what inspired you? What led you going from podiatry to launching multiple companies, but ultimately, and I meant to ask you before, how do you pronounce, is it BioXTek? Is that how you say?
Exactly. Yeah, BioXTek.
Well,
It's an interesting story. So as you can imagine, with lower extremity, there's lots of diabetics, and the population, unfortunately, is increasing in diabetics, and they have complications. And the hardest part of my world was dealing with patients who faced amputation. And everybody would cry, and it would break my heart to have this, and they would be challenging me. Isn't there something else you can do, doctor, to keep my leg, to keep this? And, it challenged me, actually. And that's what prompted me to find platelet-rich plasma in the early 80s and brought that into the paradigm. And that helped. It wasn't really a game changer, but it certainly helped heal wounds that otherwise might have been amputated earlier, or we were able to save them. But then bringing in extracorporeal shockwave therapy was also with the PRP, again, gave us another improvement level that mitigated some amputations, but still not like what I experienced when I came across placental tissue in 2007. And actually, it was one of my residents. I was teaching at medical school in Arizona, and I challenged one of my residents, actually all of the fourth years medical student, not fourth year residents, but fourth year medical students. I said, all right, it was like their summer before going off on their externships and internships and such, and so I said, listen, I'm not going to torture you anymore. You've already been through 3 years of torture. Why don't we have a fun summer project? I want you to go through the literature from the late 1800s to the 70s, and I want you to find me old medications, old treatment and why I want us to talk about why they were abandoned, or how they've innovated to become new treatments, so that you can get a historical perspective of as you're entering your new profession. So a couple of them actually came up with placental tissue, and they found a plethora of articles from 1905, a couple of authors, Sabella and Davis, 500 cases of using placental membrane on a variety of issues, from orthopedic to ophthalmic to wounds to burns, and with great outcomes and no adverse events reported. And so I had them give a presentation, and I happened, life is fascinating how you meet people. I was at a meeting, and I was talking about, I was very interested in placental tissue. And one person introduced me to another person, and I met my business partner, who's also a bioengineer. And I was saying, hey, how can we make this into an injectable? And he says, I'm working on that project.
Oh.
So I said, all right, well, how do we get started? And it turned out that these are what are called 361 product under FDA regulations at the time, human transplant tissue. And
Hmm.
so I started with just the membrane product, just taking so the membrane is made from the placental sac that holds the baby. And so there are organizations that collect this material. So I was able to get some. We cleansed it. We went through a whole process that we actually have a patent on. And so then we started with the membrane on the wounds. And wow, that with the PRP, oh my goodness, wow, we're closing wounds that otherwise I would have struggled with. And then I said,
That's
hey, can you make it so that I can inject this into these folks? And that was the absolute game changer. That was in 2007 or so, or closer to 2008. And we made a micronized amniotic membrane in amniotic fluid, and obviously everything was cleansed and tested to ensure no bioburden or infective agents or contaminants. And I injected the first patient who had to have an amputation because his dialysis was failing. We had already amputated the tips of his toes. I mean, he'd just been through the ringer. Foot was swollen like a balloon. And I said, Larry, we got to schedule you because I don't have any more magic. I said, but if you want to try, since you're already at risk, if you want to try, I just created this new injectable. And I told him what it was. And he said, hey, I'll try anything to save my life. And well, son of a gun, I inject around the wound, and he comes in 5 days later, all his lymphedema, all this swelling, this balloon of both feet. I only injected one foot. Both feet were shrunk down to almost normal size in 5 days. And this non-healing 3-year-old wound was 20% closed. And I'm like, it's got to be a coincidence. How could this be? I mean, how could this stuff work this well? So anyway, I said, let me give you one more shot. Let's see what happens. So I gave him one more treatment, and about a week passed, and he comes in. The wound is probably 70% closed. There's almost zero lymphedema or swelling in his legs, and I'm shocked. By 63 days, the wound was totally closed.
wow.
By 90 days, he was back in a regular shoe. Both extremities looked perfectly normal. He had a couple of other wounds on the other foot that healed at the same rate. And we were like, wow. So anyway, he went on, got his kidney transplant, was able to ultimately go back to work as a nurse, and became a functional human after almost 4 years. So I called all my colleagues in Arizona and I said, hey, send me the worst of your worst, the wounds that aren't healing, that you're ready to pull out your hair, if you have any. And let's see what we can do. So I treated 19 additional patients in that cohort, and all 19 patients healed 97% healed at 63 days. Now we did a follow-up for 24 months. None of them developed a secondary wound. Their vascular supply to their toes improved to greater than 70%, what's called the SpO2. Their vibratory sense. So all these patients had diabetic neuropathy. They couldn't feel anything. Well, their vibration sense improved. Their ability to sense something touching their foot improved. The neuropathy didn't go away, but their pain associated with neuropathy went away. Their sense, there was a return of some sense of sensation, but not total, but still, it was incredible. So we wrote that paper up. My colleagues all saw, my upper extremity colleagues saw these results. Did I lose you?
No, I'm here.
Because my phone flipped there.
Oh.
So anyway, then all of my colleagues started to say, "Hey, can I try some of your newfound juice?" And that's when we started to see that it accelerated bone healing. We could use it on tendinopathies. I did an Achilles tendon rupture on a semi-pro athlete, saying, "Oh, you're going to be out for a year." At 12 weeks, he was able to fully use that legs, single stance, toe raise at 12 weeks. Now, normal, most people know when you rupture an Achilles tendon, you're out for at least a year. And we were getting these people back at 12 weeks. So it was just incredible. We started treating arthritis. Then other people were treating autism and post-ischemic stroke. And over the years, it's just grew. The spectrum of pathologies that responded to this therapy was just incredible. Unfortunately, in 2019, FDA said, it's working too well. We need to control this. And so at that point, we had to shut everything down. We had to build what's called a CGMP, Good Manufacturing Process facility.
Yeah.
We had to spend lots and lots of money to build a pharmaceutical grade manufacturing facility, and now spend more millions to get clinical trials done. So we're finally at that stage, but it's taken many iterations over the last 18 plus years to finally get into this final phase. So that's the
Yeah, I was gonna
story. That
because
is the
it's
short story to your, the long
yeah, I
way
mean
around to your short question.
I was curious because you said, I mean, when you started, you were talking about 2007. And I'm like, well, we're almost 20 years later. Why haven't we seen this? Well, now I get it. Yeah, you kind of got pulled back
Yes.
about six. Yeah.
Yeah.
Well, I mean, because the results, this might be the answer to that question. But I'm going to be curious, I guess maybe more from the business perspective. Like, there are clearly some risks, which you're experiencing some of them moving into the biotech space. Like, what's something do you think most people don't realize about building a company like BioXTek?
It's a challenge. Anything like any business, anything we take in life. Um, the challenge obviously was raising money, but more importantly than raising the money was finding the right partners. This
Mhm.
was the biggest challenge. Why some of the missteps I've made is I I didn't really understand people and their motivations, and so ultimately I learned I needed strategic partners, people that were absolutely aligned with me as to what the future vision. They were aligned with my vision, not with how much money can I get off the table tomorrow, but understanding that you got to play the long game uh, and do it right, not just take shortcuts. And unfortunately, so many people want to take shortcuts and not do everything you need to bring it into mainstream medicine.
So how close to like where are you in the clinical trial process?
We're pretty far along. Obviously, we've had to raise some money. We've grown BioXTek quite substantially in the 3 years, and with our patch business, which is fully accredited and allowed to be sold. We have 3 wound studies ongoing presently for large wounds, different configurations of our membrane product. So that's been a few $1,000,000 we've spent out of cash flow. We have been in the background doing all of the determination of the toxicology, all the histology on hearts. And we've done some safety trials in using the membrane on the heart. So our first study, which has been published several papers now, is using the membrane with open heart surgery. Dr. Zane Kalpi in Arizona is our principal investigator, a well-known and prolific author and scientist and physician. So he has been placing the membrane on the heart with any type of open heart procedure, and we are able to reduce the incidence of AFib occurring after open heart, which typically occurs 40% of the time with
Yeah.
any type of open procedure or robotic procedure. We've reduced that to less than 7%, an 83% reduction in the incidence of AFib after open heart procedure with the membrane product. We're now working on a study that he's leading with ablations. So now with robotic ablations, so people have to have an ablation, not because AFib because of surgery, but for a number of other reasons where there's inflammation of the heart. And so the docs go in, they burn portions of the heart muscle to stop the abnormal electrical signal that's causing the fluttering of the top part of the heart. These type of patients have to go back multiple times for ablations. Well, if we do that first ablation and we tuck the membrane around the heart, we can reduce the recurrence quite substantially. I can't give you numbers. We don't have all the data, but the preliminary data is extremely promising. And then the other part of what's taken our time is our therapeutic, our injectable, which we now understand is exosomes, and we can talk about exosomes versus stem cells in a moment. But we've made an acellular product, so it's very safe, no risk of any type of graft-host reaction or any other reactions. We've had 0 adverse events. Is injecting it into the heart muscle after, let's say, a heart attack, an ischemic event, and we can eliminate the scarring that's developed, and we can revascularize that damaged myocardium. So we have one clinical study just about getting ready to go on the membrane that's fully approved, that hopefully will be fully approved by FDA shortly. And then our second study will be injecting these exosomes into the heart muscle. So those are our 2 big clinical trials that are coming up.
And I know this isn't in the book, but you mentioned something about a patch. What was
So
what was that?
the membrane patch is taken from the placental sac, and we have a special process so that it's well tolerated on the heart. And
I got you.
those patches are used in ablations and with open heart procedures to reduce AFib.
Okay, I was thinking you meant there was some other device or
No,
product out. I got you. Okay,
yeah, so
perfect.
those are derived from the placental sac, and then our exosome product is derived from the goo inside the umbilical cord called Wharton's jelly, and the amniotic fluid that the baby is floating in. Now, healthy babies are born, no aborted fetuses, nothing like this is used, all totally ethically and morally acceptable to everybody.
So, what are your main obstacles to today? I mean, or is it just now a matter of going through the steps and the time?
That's it. It's just working through the process. Now we're very blessed that we have a new administration, a new outlook on these advanced therapies from the new administration. So it's making the steps, hopefully. But right
Hmm.
now, it appears that things are going to get we're not eliminating hurdles, but the hurdles are a little more accessible to achieve getting over. As we see this new administration in the FDA and a different way of looking at treatments as we move forward with this new group in control. So we're very excited about it. We've obviously been talking with the powers that be as much as we can get in touch with them. And we seem to all be on trying to achieve the same goal of bringing these very safe therapies to people sooner than later.
Have you, and we were talking a little earlier about how obviously AI is something I'm really interested in. Have you used AI during this
Well,
process?
we use AI for not really for the science piece, but we use it for we're trying to develop it. It's still not quite there, but in
Hmm.
evaluating the donors, right? So there's a lot of work in getting the medical history, the social history, the family history, looking at the blood work of the donor mother to ensure that we have very strict criteria. We have almost 60 pages of inclusion, exclusion criteria for the tissue we can use for these products. So AI, we're getting much closer to use the AI instead of human. Well, it's going to be both. But
Right.
humans, it takes a good hour and a half for each donor to go through the process for them to say, yes, it meets the criteria. Then we have a third party to review it. So if we can shorten that down to, even 10, 15 minutes, it'll give us some room. So that's where the AI is going to be quite helpful for us. We are I don't know if you're aware, in Florida, just July 1st, the stem cell bill was enacted here in Florida, which will
Yeah.
allow Floridian physicians to use our therapies for pain, wound care, and orthopedic issues. So we're going to have a registry, obviously, collecting all that data from the patients, all of this safety data, and that's really what FDA is concerned about. We're just going to keep plugging all that safety data and giving it back to the FDA to try to move
Hmm.
all of these steps forward faster. So instead of 5 to 10 years, hopefully we can have these approvals in 2 to 3 years.
Okay, yeah, I was going to see if you have a guesstimate on when we could actually see this out into the marketplace.
Well, now that we're going to be able to collect this data on a wide group of patients, high diversity, wide demographic changes, so collecting this data from the patients in Florida is going to really help accelerate moving this forward. We're talking with decision makers about trying to how do we mold it so that real world evidence can be evaluated by FDA to allow us to accelerate getting our approval. So it's a combination of pieces here that have to come together, and hopefully we're going to see that happen.
Well, there's no doubt this is, I had no idea this was in the works. It's pretty exciting stuff. Knowing what I do know about diabetes, specifically amputations, that whole world is what I truly can't wait to follow the research and when you can release it, see what results you guys are actually having on being able to prevent amputations. To me, that's just huge.
Yeah. Yeah. Well, it's partly the patient has to participate, but they
Yeah.
have to have better food. They have to improve their microbiome. They have to give up their Snickers bars and Ben and Jerry's. Uh, if we
That's interesting. So, as part of the process, you are addressing those.
Yeah, yeah, it's the whole patient. I mean, I can't
Yeah,
just
perfect.
I heal a wound without addressing the other needs
Yeah,
of glucose control, inflammation control. All of these components go into healing these folks so that we can get better blood flow into the extremity. One of the things we
right.
found with the injectable is we see angiogenesis, new blood vessel formation. So we can inject above a blockage in the lower leg if it's not totally occluded, and we'll
Hmm.
see new blood vessels forming over several weeks to increase the blood supply to the extremity. So, yeah, that's why we're fairly confident. That's why the first 19 patients in our 24-month surveillance didn't develop any secondary lesions, is because we improve their blood flow to their extremity.
Yeah. Well, it's going to be an exciting 2 to 3 years for you.
It's already been an exciting time.
Yeah, I'm sure it has been. Yeah, really
Yeah.
well done. I mean, I have to say, I have to commend you for your persistence
Yeah, well, thank
because
you. But
this has been a long journey for you, and I know there's got to be a little bit of a glimmer of light at the end of the tunnel for you.
well, really, the joy is when we get to use this on patients, and I see the improvement. It's
Yeah.
they call me and they just are joyful that their wounds heal. But what we did, uh, kind of off book, if you will, is even during COVID, if we do use our stuff as a breathing treatment,
No.
we can eliminate the COVID infection and the fibrosis that occurs due to
Mm.
the infection. Even the long haulers, some of them, friends and family, obviously, we would do anything to get rid of some of their symptoms, and we did these nebulized breathing treatments, and they all, to a person, did well. And frankly, the thousands of patients that were treated between 2007 and 2019, not one adverse event. The worst thing that happened was nothing. Less than 10% non-responders. So if that's my worst complication, I'll take it any day.
Seriously. Well, and then to be able to have that impact on a much larger scale
Yes,
is
yes.
is
Going
good.
from my one surgery, one patient at a time, to be able to help many at a time would be a great joy.
Yeah, well, thank you so much for sharing that story. It is one I know I will certainly be able to or be excited to follow, and we're connected now, and I'm gonna be watching.
All right. Well,
I
I
appreciate
like
you
it.
taking some time today.
Oh, my pleasure, Michael.